So collecting the right data at early phases within drug development or intervention development is, of course, a key challenge for life science companies around the world, not only in the context, of course, of the UK, but at a global level, with sets of legislation and requirements and cross-border collaborations that are constantly changing. So specifying and understanding the path to the right evidence package is a really complex task. The best approaches that I see to this within life science companies come from those who engage on this problem early and actually reach out to the HTA bodies around the world to actually have those conversations around the quality, type and specification of evidence that will be needed to support great decision making. There are, I think, over 60 different permutations of ways to seek advice if you look at a global level. So picking the right ones to engage with at the right time is in itself no mean feat and probably requires its own decision manual. But actually, once you get in front of the different decision makers, having real clarity on the questions that you need to ask to be able to make great decisions within development programs is key. And being able to have that early dialogue, which in the case of the UK is so favoured by organisations like NICE and new innovations like the innovative licensing and access pathway. We've got the right channels, we've got the right mechanisms. The challenge for life science companies is to know how to use them and to feel trustful and open in being able to walk through that door and have conversations that don't necessarily have an easy or straightforward answer, and be willing to listen and embrace the context and advice that's given. Andy, what do you think from an NHS perspective?
Well, I think, to be fair, this is much more your world, Esther, than mine. But I think that what we do have available in the NHS is a whole load of real-world data that can help inform and provide some valuable insights early on to be able to kind of understand not just the market size, but the potential benefits and how they may play out. It gives you an opportunity to conduct some early economic evaluations to be able to try and better understand. And of course, when NICE is now starting to look at inequalities, it helps you better understand those populations and, again, the different levels of outcomes and the variation and the disparities in those outcomes kind of going forwards. And I think a lot of it comes down to what you've already talked about. It's engagement with the stakeholders, engagement with the agencies early on. I believe there's a process, or early phase process around the parallel scientific advice process by EMEA that kind of talks about how we can use this data in the right way. But I said, you know much more than I do about this.
Yeah, I mean, there are lots of different ways that companies can engage, and in lots and lots of different combinations. I mean, thinking about the UK specifically, for example, it's not uncommon to seek joint advice from NICE and CADF in harmony. So taking a kind of UK and Canadian perspective, or to look at parallel advice with the regulatory bodies. My own experience recently of the ILAP process, the innovative licensing and access pathway, has been really encouraging. I think that's a really unique way on the global stage of multiple stakeholders within a system being able to come together to provide advice in a timely manner. So again, the experience of being able to sit around a table, albeit virtually, with representatives from NHS England, as well as from NICE, the SMC, and of course the MHRA, and patient advocacy organisations, to be able to gather that real sense of what matters and what's important, and how to be able to use that in development to ensure that the right evidence can be brought forward. So I think the UK is really leading the way in terms of thinking differently about how to embrace those multiple perspectives. But of course, the conversations then need to be ratified up on a global level, because often we're dealing with 1 or 2 phase 3 programs. We can't, sadly, be in a world where we're designing country-specific evidence programs. So there will always be trade-offs to be made.